of our alumni webinar series conducted by Dr. D.Y. Patil College of Physiotherapy, Pimpri, Pune. So today we have with us Dr. Chitra Rawal, and Dr. Chitra Rawal is our alumni from the batch 2001. So she is currently working as a physical therapist at Generations Healthcare, California, USA. Dr. Chitra has done her master's from Loma Linda University and graduated in the year 2009. Her key research studies are on geriatrics and low back pain. Now, she has worked in outpatient clinics, acute settings, hospitals in Mumbai, Pune, and USA. Now, she is a certified Mulligan therapist, and also she's done her certification course in kinesiotaping. She is a licensed physical therapist in rehabilitation unit, mainly focusing on geriatrics. So I welcome you, Dr. Chitra,
Thank
and
you.
over to you. Yeah, over to you. You can start with your presentation.
Okay. So first of all, I just wanted to thank everybody, Dr. Tushar Palekar, Dr. Gaurang, Dr. Rupa, Dr. Rati, and the rest of the staff that I've had a pleasure of, being with from 2001 to 2006. I have learned a lot, basically, and I've applied all that knowledge that I've learned back from India into US. So it's kind of amazing when you talk to students over here and talk to other patients, and you spread your knowledge of what you've learned in India. So it was a good plus being at DY Patil. Okay, so I'll be sharing my screen now. So let's see here. Okay. Okay, so I will be talking about low back pain in older adults, basically geriatrics. I do work in a nursing facility here, which deals with a lot of older population or anybody over the age of 65. We do occasionally even get people above the age of 50. And at least most of them have said that they've had low back pain. So how do we deal with that in a nursing home setting? Because we deal with patients having a lot of other conditions at this age. So let me start the slideshow here. Okay. So first of all, the presentation purpose itself is understanding low back pain in the elderly, differential diagnosis, treatment approaches, and we'll see what we can do as PTs for the same. So what is low back pain? Pain which is in the area behind the belly from the rib cage to the pelvis, also called as the lumbar region. It may or may not radiate down to the lower extremities. It can have origins elsewhere, which may refer to the low back. So this is one thing that you guys should know about as well, to look for other areas of pain that might be referring to the low back. Okay. So individuals above the age of 55 to 60 years, currently due to maybe their lifestyle, diet, environment, individuals older than 75 are 3 times more likely to experience severe low back pain versus those between the ages of 50 and 60. Now, untreated low back pain in older individuals causes rapid decline in functional ability, basically even their sleep disturbances, poor memory, decline, inability to participate in community activities, as well as social participation, along with a lot more falls, depression, decreased appetite, and malnutrition. So they're likely to report pain from degenerative changes, basically due to aging again. Over here in the United States, it's one of the top reasons people visit physicians basically with this disability. So most back pain in older adults have a recurrent or episodic course. Women do report higher prevalence than men. There is one reason why this happens. It's because usually they end up with osteoporosis more than men, and this causes weakening of the bone structure in the low back spine, which causes women more pain. Okay, next point here. Just a second. Okay, so here now, what are the common causes and diagnosis? So most common and top causes of low back pain can be osteoarthritis, spinal stenosis, sort of visceral diseases that may be happening, degenerative spondylolisthesis, spinal compression fracture, spinal malignancies, and one other top cause that may happen in older individuals that may be missed most of the time is an abdominal aortic aneurysm. So let's see ahead and see each one of them in detail. So usually osteoarthritis occurs when the cartilage that protects and provides cushion at the ends of the joints, as you can see over here, this is a normal spine, just for example, and the picture on the bottom represents osteoarthritis. So there's damage to the bone from bone wear and tear, and further damage to the end plates, to the facetal joints, to the spinous process, to the nerve roots coming out, and this causes a lot of great pain, due to which people usually come to the clinic. So let's go back again and see here. Now, there might be stiffness after prolonged inactivity, or on getting up in the morning, or with movement of the involved area of the spine. There might be difficulty performing normal daily activities such as dressing mainly and bathing, as well as walking and standing as the condition progresses. Facet joints can also be affected. There might be swelling, pain, inflammation occurring with the breakdown, along with formation of spurs. Now, in the picture that I showed you guys, you do see bony protuberances that occur along the spine. They're called as spurs. And these bony growth formations basically cause more and more pain as they grow, and they cause spinal stenosis and a lot of other problems in the spine. Pressure from formed spurs may cause compression of the spinal nerves. It may cause weakness and pain in the legs, stiffness to the low back as well. And it's most common, like I said, in women versus men after the age of 45. Okay, so let me go back here again. So yeah, so here's the picture. Okay, normal spine, osteoarthritis, damage to the bone and cartilage, flattening of the disc, loss of height in the spine, leading to compressed and pinched spinal nerves in the lumbar region again. Okay. So what are the things that we can use as physical therapists, or rather treatment approaches that we can use in our clinic? We can use modalities, heat, cold, transcutaneous electrical nerve stimulation units, manual therapy, soft tissue massage, specific low impact activities that will strengthen your spine, abdomen, and hip muscles. Your physical therapist can also teach you how to get in and out of bed, basically ergonomics again, correct toilet modifications. Nowadays, people have Western type toilets. Those are actually much better for back pain, but there's modifications that you can also make to such toilets as well. How do you get in and out of a chair, how to bend and walk with more ease, as well as get in and out of a car or auto. Now, manual therapy, in this case, your physical therapist may use gentle hands-on techniques, very gentle, because you need to see the age group of such individuals. This is very different versus working with patients that we've seen in outpatient clinics, which are more younger, people who have had injuries from sports as well. So you have to be very gentle with this population, and it basically helps to improve their spinal flexibility as well as ease stiffness. Continuous passive stretching exercises on the limbs, your lower extremities, as the patient can tolerate. To prevent muscle tightness, you have to consider mainly the hip flexors, hamstrings, and heel cords. Okay. So after Osteoarthritis, we have spinal stenosis. Now, this is narrowing of the spaces within your spinal canal, which causes compression of the spinal cord and the nerve roots exiting the spine. Patients may experience pain, tingling, numbness, and muscle weakness. The symptoms can worsen over time, and if compression or stenosis is severe, it may cause loss of bowel and bladder and claudication in the elderly. This is a medical emergency, so do not avoid symptoms if patients are saying they've suddenly lost their bowel and bladder mobility. Have the MD or emergency look at it. Patients may have trouble walking certain distances or find that they need to lean forward, in such cases flexion at the spine to relieve pressure on their lower back. So bone spurs, that form from osteoarthritis can grow into the spinal canal. There are cracks that may occur in, the disc's exterior part, and it may allow some of the soft inner material to escape and press on the spinal cord or the nerves, along with the narrowing of the canal itself. The thickened ligaments can also bulge into the spinal canal. There might be tumor growth that may also cause spinal stenosis. Injury from any sort of trauma, displaced bone, or mainly post-spinal surgery, swelling may also cause spinal stenosis. Surgery, may be performed to decompress at an advanced age, but that should be taken very carefully. Now, one thing I wanted to talk about was that you have ligaments at the back of the spine. You have the ligamentum flavum. It's a short, but a thickened ligament that connects the laminae of the adjoining vertebrae. And over time, this can lose elasticity and its strength, and it causes a buckling that happens towards the spinal, column. And this is due to the loss of its elastic fibers. So if the ligament calcifies, it does cause hypertrophy, and it can lead to spinal canal stenosis as well. Okay. So in the picture here, let me show you guys. This is a picture, a lateral view of the MRI of a patient with spinal stenosis. As you can see here, between L3 and L4, there's a disc that has prolapsed into the spinal canal, spinal cord. What's happening here is that it's pressing on the spinal cord, causing narrowing of the entire structure around this area. And not only that, but there seems to be some sort of bone spurs and a lot of, adjoining vertebral body, deformity happening over here. So this entire area has stenosis happening between L3, L4. So what are the treatment approaches that, as a physical therapist, you can treat your elderly patients to? So the physical therapist may encourage more flexion exercises of the trunk because it does open up the spinal canal. You have to be careful that the patient does not have any other, conditions that limit flexion as well. Flexing the lower back does open up the passages where nerves exit the spine, and it also allows nerve irritation or impingement to resolve. Patients with spinal stenosis often feel better when bending forward, like I said, such as leaning on a shopping cart or walker. If you go grocery shopping, if you see someone leaning on a cart that's not young and might be older, it might be because it's causing a lot of pain relief for them. I have seen a lot of patients here in grocery stores in America. You see a lot of the older people basically leaning on carts. It just makes them feel better. When you tell them, you should stand up straight, like as physical therapists, we say, they might say, no, it just makes me feel better. I've been this way. So consider this approach as well. For older adults, a safer way may also be to lay on their back on a firm bed. Make sure that the bed is elevated, not on the floor, because for older people, it's difficult for them to get up from the floor again. And to gently pull their knees, flexing to their chest until a comfortable stretch is felt. After about 20 seconds, slowly return to the starting position. Patients may complete 5 repetitions of this flex. You can do it several times a day as well. There's another pose called as the balasana, a child's pose. And what this does is it gently stretches the lower back. The muscle it stretches is your latissimus dorsi. What you do is from the hands and knees, bring your big toes to touch, sit back on your heels, lengthen your spine, and rest your forehead on the floor. I'll be showing you guys a picture of what that looks like. So here, the first picture here, like I said, flex forward, you will feel less pain if you have spinal stenosis. That's one of the signs of patients that might be having stenosis. They might have more pain on standing upright in extension. So we might tell them stand upright, but no, that's not a good way. The child's pose that I was mentioning is spreading your knees as wide as your mat and let your belly rest between your thighs and rest your forehead on the floor. This causes a stretching of the muscles in the back right here. The next condition is degenerative spondylolisthesis. So the word spondylolisthesis comes from 2 parts, spondylo, which means spine, and listhesis, which means slippage. So in Latin words, it means a slipped vertebral body. The intervertebral disc acts as a shock absorber in between the vertebrae, while the paired facet joints in the back restrain the motion. So what happens is that they allow the spine to bend forwards in flexion and backwards in extension, but they don't allow for a lot of rotation of the trunk. So with age, as the facet joints age, they can become incompetent and allow too much flexion, allowing one vertebral body to slip forward on the other one. A degenerative spondylolisthesis typically occurs at one of the 2 levels of the lumbar spine, and you'll commonly see it happening at the L4, L5 level at the lower spine. Sometimes you do see it at the L3, L4 level as well. So let me show you guys a picture of what this looks like as well. Notice over here in the first picture, there's a slippage of L4 over L5. We don't know the percentage. You can measure the percentage. In my next slide, I have the grading system. Second picture here also shows a slippage of the L4 over the L5, as you can see. Now with degenerative spondylolisthesis, there is a forward slipping of the vertebrae, which is called anterolisthesis, resulting into a narrowing of the vertebral canal and neural foramen, and also compression of the L5 spinal nerve. Sometimes you might see retrolisthesis as well, and that's the backward slipping of the vertebral body, and that's usually asymptomatic as per what we've seen in a lot of patients. Patients often also may complain of sciatic pain, which is an aching in one or both legs, or a tired feeling down the legs when they stand for a prolonged period of time, or heaviness when they try to walk basically a longer distance. Patients will exhibit tight hamstring muscles, decreased flexibility in the lower back, and difficulty or pain with extension. So spondylolisthesis is easily seen on a lateral-sided lumbar X-ray. So that's one way to see what the grade of slippage is. This slide here, I have the Meyer-Dane grading system to classify the degree of vertebral slippage. So in the picture here, we have grade 1, which is between 0 to 25% of slippage over here, this little space here. Grade 2 is 25 to 50% of slippage. Grade 3 is 50 to 75% of slippage, which is a lot. Grade 4 also 75 to 100%. And the last one we have is over 100%, which is complete spondyloliftosis, which is falling of the supporting vertebrae. And that is also a medical emergency. So always have a look at the x-rays. You can take any number of x-rays to confirm your diagnosis as well. What are the treatment approaches? A lot of these treatment approaches that you guys will notice I'm talking about do overlap each other with low back, especially in the older population. You have to be careful in your approach. You cannot be doing the same things you're doing with younger adults in outpatient clinics, or inpatient clinics. So what do we do in case of spondylolisthesis? So here, rehabilitation focuses mainly on specific training of muscles surrounding the lumbar spine that provides stability, and it can be very effective in reducing and preventing pain and instability. Now, these muscles are the deep abdominal muscles, transversus abdominis and the internal obliques, and the lumbar multifidus. When you train these muscles, because they're main muscles for stability, it provides a solid foundation for the spine. Pain management, of course, stretching. This is very, very important. Stretching exercises for key upper and lower extremity muscles with emphasis on neutral spine alignment and non-weight bearing postures. So supine 90-90 active knee extension hamstring stretches. Child's pose again, like I said. Supine pectoralis stretching. Supine or sideline hip flexor and quad stretching. Supine figure of 4 piriformis stretching is also very beneficial. Stationary biking is also a very reasonable option for the elderly population, as activity in the sitting position should be tolerable for them. Another option is hydrotherapy, pool therapy. Warm water, of course, physical therapy done while in a warm swimming pool, as the water provides support and buoyancy also, and the patient is allowed to exercise in a flex forward position. Less risk of causing pain at other places in the back and less injuries when doing hydrotherapy as well. Also, okay, so now we all know that everyone does need good massage from time to time. Physical therapy also encourages one to perform massage on the low back. It does loosen out the superficial and deep layers of the muscle, but you have to be careful. So the next one we have here is spinal compression fractures. So vertebral compression fractures usually are caused by osteoporosis, as we first mentioned. Cause of fracture may be simple, very simple activity, such as stepping out of a bathtub, sneezing, lifting, or trauma. And it may also result from the load, which is caused by muscle contraction, also by a lot of corticosteroid use. You have to be careful when prescribing corticosteroid injections. Surgeons do recommend it for pain relief, but having too much also is not a good idea. Usually this occurs at the lumbodorsal junction, mainly T8, T12, L1, and L4. So they can be different types of fractures as well. They can be wedge fractures or burst fractures. Women are more prone again from osteoporosis, postmenopausal. They should, first of all, whenever you see a fracture in an individual in the lower spine, rule out any malignancy if the fracture occurs, and also if they're below 55 years of age, if they've not had any trauma or come with a sudden history of pain, always rule out malignancy. There is tenderness and sensitivity near the vertebrae. So here we have types of spinal fractures. We have a wedge fracture picture here and the Scotty dog, which I'll explain in a little bit. So most of the damage that's done is at the anterior part of the vertebrae. So the wedge fracture that we see in the picture, you see the vertebral body that's fractured on the anterior side. It forms when the anterior part of the body crushes from trauma injuries, like I mentioned. The middle column remains intact and may also act as a hinge. So this results in loss of anterior height of the vertebrae while the posterior height remains unchanged. As the collapsed anterior vertebrae fuse together from bony spurs and a lot of bone formation happening, the spine bends forward, causing a kyphotic deformity. So the fracture is usually stable and rarely associated with neurological compromise unless, of course, the person's been in a horrible accident or trauma. The picture on the right that I have, it's called as a Scotty dog. You see a little dog sort of image inside. So this is actually a defect or a fracture that occurs in younger individuals in the pars interarticularis, and it is seen in adolescent athletic males, mostly at the level of L5. Normally, when you see a Scotty dog, the majority of athletes, if they have trauma happening to their vertebrae, the Scotty dog will show abnormal. I'll show you a picture later if I have any of the images of such injuries, but since we're talking about elderly back injuries, I'll talk about that first. Um, so the next fracture that we have is a burst fracture. This can be a medical emergency again. A burst fracture usually results from significant trauma that compresses the bone, and such, you can have a motor vehicle accident or maybe a severe fall. I've had a patient here that actually was about 70. He was male. He fell from his ladder while he was putting up Christmas decorations. And when we saw the fracture, uh, 2 levels of burst fractures, very severe. We had to call 911. So this is a medical emergency again. Burst fractures account for 14% of all spinal injuries. Bone fragments can also be displaced into the spinal canal or foramen, which is the exit route for individual nerve roots, leading to pressure on the nerves and compromised function. The potential for spinal cord injury in such cases is very high. So always be careful when you see such x-rays. What are the treatment approaches that we have for fractures? So you can have obviously analgesics for pain relief. If it's not that severe, option for bracing, also to heal and stabilize. Decompression, which is removing part of the bone, which is compressing the spinal cord. You can have a laminectomy, which is removal of the lamina. Corpectomy, which is removal of the vertebral body, the entire vertebral body. You can have a vertebroplasty, which is injecting acrylic cement into the collapsed vertebrae to stabilize and strengthen the fracture and vertebral body. A kyphoplasty, which is the most commonest method which I've seen being used in America, where cement is injected into a cavity which is created by a high pressure balloon. So this is preferred over vertebroplasty because it restores height of the vertebrae. And if you need, they also add spinal fusion with screws and plates if the bone density is okay. So again, in this case, you have to check for osteoporosis. Strengthening exercises, weight-bearing exercises, avoid inactivity. A lot of elderly individuals stop moving. This causes most of the back pains that I have seen. So always prevent inactivity. So another type of back pain that we normally see is due to spinal malignancy. Majority of the spinal tumors are related to metastasis from the kidney, breast, prostate, or lungs. The symptoms are progressive and they're localized or sometimes radiating pain, which also gets worse by movement. It's worse at night and does not ease with rest. So it may, the lab findings may show hypercalcemia, elevated erythrocyte sedimentation rate, increased temperature, fever, spinal cord compression, loss of bowel and bladder, weight loss. So spinal malignancies can also be meningiomas, which is a type of mass that surrounds the spinal cord. Multiple myeloma, rare form of cancer, which causes an increased production and function of plasma cells in the bone marrow. The cells all clump together to form tumors around the spine. Now, you might also see increased calcium in the lab findings. If you see lab reports and you see hypercalcemia, it occurs when cancer spreads to the bones, and too much of calcium is basically released into the bloodstream from the bone. And another symptom you might see in patients is constipation, anemia, lack of color in their skin or pallor, bone pain, rib pain, increased or actually decreased WBC. So let me show you a picture of that. Yeah, so over here, We have a picture of spinal malignancies. The first picture here, I've put an arrow that specifically points to the part of the malignancy in the spine. It's at the vertebral body as well as the facet joints, encroaching the spinal canal, spinal nerve that exits the nerve roots. Let's see, the second picture also shows the same thing here with it compressing the anterior part of the vertebrae. The third picture is also a different version of the same picture, and the white part that you see there is the spinal malignancy and tumor. So what's myelopathy? You might have heard this term. This indicates very high level, high grade spinal cord compression. The symptoms are actually dependent on the area where the tumor is located. There's a lot of pain. You might see weakness, paralysis, loss of sensation, light touch, pinprick, proprioception, abnormal reflexes, impaired balance and coordination, autonomic changes, bowel and bladder, of course, again. In the picture that I have, this shows the level of high-grade spinal cord compression, and patients will report pain because it's compressing the nerve roots. So this is also a medical emergency as well. What are the treatment approaches to malignancy? You have to be very, very careful. Pain medication. Now in US, I have seen surgeons prescribing Botox. It is injectable and it's medication that's used to stop muscle contractions if it happens because of the pain. Relieving symptoms using bracing and support for joint stability and functional positioning. Surgery, minimally invasive surgeries, complex procedures to remove tumors, decompress spinal cord, and stabilize the spine. You can use modalities, but you have to be careful in which type of modality you use. Some can be used to improve motor weakness, strength training as well. Over here, when we get orders from the surgeon, they send us orders that typically mention no BLT, and that means no bending, lifting, or twisting. So these are some precautions you really have to take for the first 5 to 6 weeks after surgery or spinal malignancy. Activity restrictions to promote safe mobility and allow healing. No bending, no forced flexion or extension of the spine. No lifting greater than 5 to 10 pounds. No twisting of the spine again, 5 to 6 weeks, but you have to bring it on gradually. We do consult with the surgeons on a week-to-week basis and let them know how the patient is doing as well. It is very important to have an understanding of primary and metastatic spinal tumors, including various treatment options that will affect the role of physical therapist. Now, something that people may or may have not heard of much because it sometimes bypasses people's notices. They don't understand why the patient is having pain in the abdomen. So one of the reasons patients may have referred pain to the back that is actually coming from the abdomen is because of an abdominal aortic aneurysm in the elderly. So an aneurysm is basically weakening or enlargement of the abdominal artery, the aorta, caused by weakening of the arterial wall. It's one of the most commonest places for aneurysms to form, which is the abdominal aorta. Lower abdominal or back pain is something that's commonly seen. Patients may have heart disease, hypertension, peripheral arterial diseases, atherosclerosis, poor circulation or hardening of the arteries. This can also lead to the aortic aneurysm. One of the symptoms is a strong pulse that you might feel in the abdomen. It is life-threatening and does require immediate attention. An endovascular grafting technology is possible if caught on time. So in the picture, which you guys see, a normal aorta looks like the picture on the left. If you see an enlarged aorta, this may rupture and cause an aortic aneurysm. So always be careful when you do differential diagnosis in patients, especially when they're older. Now, what is the role of physical therapy? I've described a couple of roles. But what more can we do as therapists in treating the patient as a whole? Because not only do they have pain in one part of the body, but they can come in with a lot of comorbidities. Usually, when we have patients come in nursing homes, they might have COPD, they might have hemiplegia, they come in with fractures of the hip, the knee, but it might also have back pain. So, how do you treat someone who has more than 5 or 6 comorbidities? So the treatment basics here are rest from aggravating activity, avoid prolonged sitting, driving, bending, heavy lifting and twisting. Heat and cold are the basics that we use. Be careful when you apply heat packs to older individuals. A lot of people do not prefer cold, so also take a note of that. Positioning when they're sleeping. For adequate support, use a small pillow for your head. If sleeping on their back in supine, try putting a pillow under the knees, or if you prefer to sleep sideline, put a pillow between the thighs. I've seen that also helps a lot. And if you are side bent, a folded towel under your waistline also will help manage the pain. So, pain management. What do we actually do for pain management? Hot packs, cold packs, a transcutaneous electrical nerve stimulation unit. I recommend every household to have at least one portable unit at home. It helps in any sort of pain, whether you're young, you're old, and it's very useful to have around in the house. Ultrasound, interferential therapy, current therapy, laser therapy. We have applied laser therapy to a couple of our patients where I work at, and that has been very beneficial. Gentle mobilization techniques, ergonomics, postural correction, lumbar support, muscle relaxants, painkillers, which have to be approved by the physician. In US, you just can't get over-the-counter medication. You have to have a prescription order. Taping techniques. You have to be very careful though when you apply taping techniques. The skin in older individuals is very fragile. And you have to be careful that they don't have cancer, infections, sores, fever. There's special different type of tapes that you get if you want to use them for older individuals. And one tip that I did receive from another physical therapist was that if you apply the milk of magnesia on a cotton bud, apply it on the skin of the patient and sort of do a testing, see if the tape is okay for them. If you see irritation, it's not good for them. But if you apply a layer of milk of magnesia and then apply the tape, there's less chances of irritation for the skin, and it's better for older individuals. Um, so as PTs, what positioning techniques can we provide to our patients who have low back pain? We have commonly seen TLSOs, LSOs also, thoracolumbo-sacral orthosis. The picture on the right you have is an AFO, an ankle foot orthosis. These are used when you see foot drops or when you see nerve damage causing foot drops from low back pain. When we brace patients, it's mainly a conservative care measure that we prescribe along with the surgeons, the role of the nurse as well in our nursing home. And there's a lot of postural correction techniques that you can provide to your patient along with the stretching techniques that I've described. It does help with proprioceptive awareness for the patient. And it promotes a safe core muscle strength. It tells them how they should be actually standing and how the posture should be. AFOs also provide proprioceptive input to the patient when they step, if they have a foot drop. So range of motion, flexibility, very, very important. People stop moving as they get older for some reason. You have to have them be active. The goal is to keep a functional pain-free limit with pre-op and post-op patients. It must be cleared from your surgeon or MD, followed by gradual progression of range of motion. Gentle stretching passively to the limbs to prevent muscle tightness. Mainly hip flexors, hamstrings, tendo Achilles. Treat spasticity if there is any from spinal cord injury and prevent joint tightness. You can apply Mulligan's and McKenzie techniques, but it is contraindicated in some cases of stenosis or if there's some malignancy or inflammation that's happening in the spine. So you have to be very careful of this. Um, also, gentle mobilization techniques, you can provide a printout of exercises to the patients to perform with pictures. That helps them more than just explaining to them verbally. Strength training. Post-surgical patients should focus on light lower extremity strengthening exercises and static exercises. You can start strength training 5 to 6 weeks, mainly after spinal surgeries, and start with isometrics, gentle progressive exercises, resistance exercises that they can do in supine. Gentle core muscle training from supine to sitting also helps. Abdominal muscle strengthening in supine with knees bent. Core muscle training, and the core is also compromised of several muscle groups, including the transversus abdominis, diaphragm, and pelvic floor muscles. So focus on this also because a lot of patients have weak core muscles. If you have a weak core when you're younger, you will have back pain as you get older, and just trying to strengthen your back as you get older from scratch is very hard. So always make sure that you have a very good core. Progressive resistive therapeutic exercises also keep the precaution of bending, lifting, and twisting in mind. So be careful when you do strengthening activities. Okay, so the picture we have here, it's just a picture that shows that you have to have an active lifestyle. And if you have an active lifestyle, it's a very healthy lifestyle. You have to read, learn, apply your knowledge. The reason I put a caveman in this picture is just to describe that prehistorically, way back, people were so active. All they did was work outside and do things. Nowadays, we've been sitting in chairs, not moving around too much. And especially because of the COVID situation, people are working from home, ruining their backs. You know, older people are not moving around much because there's restriction in going out. So make sure that you do have an active lifestyle. Some literature and references here. And yes, so if you guys have any questions, thank you. You can ask questions also, so let me know. Thanks.
Thank you, Dr. Chitra, for your wonderful session and giving us so much of information regarding management of low back pain in elderly population. Thanks a lot. Thanks
You're
again.
welcome.
Okay.
Yeah, it was my pleasure.
So, okay, thank you so much.
Thank you.
So tomorrow we have with us Dr. Sudhi Kale. He will be speaking on legal aspects in physiotherapy at 3:30 p.m. So be tuned with us by 3:30. Thank you.